Hello, everybody. Today I will be talking about clinical reasoning, and these will be the content of the talk. Okay, and I'm going through what is clinical reasoning. I'll be speaking a little bit about the challenges when we try to teach clinical reasoning to our students. What is the advantage and also impact of learning good clinical reasoning to our patients, and as well as there's benefit to us doctors. What is the process of clinical reasoning, and how do we teach clinical reasoning to our master students as well as our undergraduate students, and other type of techniques that we could use in order to practice clinical reasoning, including reflection, metacognition, as well as deliberate practice, and finally how we assess clinical reasoning in our practice. So what is actually clinical reasoning? Now, some people might call it clinical judgment, some people call it problem solving, some people call it decision making, and some people call it critical thinking. Now, these terms are actually interchangeable. Hoffman in 2007 what calls it a process, and basically to collect cues, we process the information, we understand the patient and plan and finally implement interventions to get some outcome in which we eventually evaluate and reflect upon and learn from the process. I prefer Anderson's definition, in which I feel it's more of a skill. It's an ability to integrate and to apply different types of knowledge and to weigh these evidence and critically think about arguments and to reflect upon the process to arrive at the diagnosis. Why is it difficult to actually teach clinical reasoning? Now, there are multiple factors. First of all, um, clinical reasoning depends a lot on the practicing clinician, the person's attitude, philosophical perspective, as well as preconception. Um, and when a senior clinical physician, or a surgeon um, sees a patient, very often they go through an automatic process, which an observing student or a master's candidate or a master's student finds it very difficult to grasp how we come to that kind of decision. And it's really dependent upon the critical thinking disposition that's already within the practicing clinician, and very often it's not a linear process. It's an ongoing process with a lot of series and a lot of spiral that's linked with a lot of other clinical encounters. There's also a very interesting theory called a dual theory when it comes to clinical reasoning for our patients, is that a lot of clinical clinicians, they use a combination of both the intuition as well as analysis of the case into coming to decision when they do clinical reasoning. So it is not as straightforward as we think it is. Why is it important? Why is it important that we learn proper clinical reasoning, or why is it important that we teach proper clinical reasoning? Well, first of all, with poor clinical reasoning comes poor judgment, and this will actually cause adverse clinical events and can lead to complications. They notice a significant number of patients as a failure to rescue when people make the wrong decision. Um, Besides by benefit to our patients, they also benefit the doctors and the clinicians themselves, whereby it gives them an opportunity to reconsider and to review their own clinical reasoning. It improves their time to getting a diagnosis when they follow a certain way of diagnosis and clinical reasoning. Avoids assumptions, as well as reduce unnecessary investigation costs when they justify the reasons of their management. And of course, with an improved um, uh, uh, decision making, we also have improved in patient satisfaction. Now, the process of clinical reasoning is, it looks more like a cycle. First, we look at our patient, then we consider our patient's situation, then we collect cues and information. Subsequently, this information is being processed and we make some decisions on what we're going to do for our patient after identifying some problems. We take an action, then we evaluate and reflect to see whether it's correct or not. Now, very often it doesn't just follow in a straight line. It goes back and forth, and is also very dynamic. So it is what makes clinical reasoning challenging to teach, I would say. Generally, for surgeons, I think the most important thing is to have a diagnosis, a differential diagnosis, so we can implement our our management quick and fast, and we must be able to judge and identify the proper management, as most of our master students who will pass will come out to lead a team, and they will be able to take on this role. So it's suggested, this is some of the process which I would suggest to give thorough directed clinical history and come up with the initial hypothesis generation, in which we can give subsequent testing through specific questioning. And through this, we can, the trainee needs to do a physical examination is directed at gathering further data to either confirm or refute the hypothesis. Okay. Based on this history and physical examination, they need to select a primary diagnosis and also a differential diagnosis in this order of likelihood. And to investigate the patient, they need to go through a thoughtful and critical selection so that they could gather additional data in order to manage the patient, and finally implement a targeted and rationalized management plan. Although there is a series of steps to take when we collect this kind of information to obtain clinical decision, it has a lot of hidden aspects in it. For example, the master's candidate will need to know what is the relevance of the data. They will need to know what is the piece of data which will make the hypothesis more or less likely. They will need to know and they need to interrelate this data with other data which is already gathered, for example, what can be found on their own notes and so forth. They will also need to know which is the data which is most critical to present, either positive data or also relevantly negative data. In undergraduate, most of the time this could be well taught in PBL, whereby they can teach the students early development of diagnostic skills, communication skills, as well as teach a little bit about cultural sensitivity and probably not have any assumptions when they see a patient. So what are the educational strategies in order for us to teach clinical reasoning? We need to know that we need to integrate the knowledge and apply it to patient care, but this is actually a very complex process and it's quite challenging. And clinical teachers can actually greatly enhance the students' ability to reason. It's just like driving a car. We can always teach the students mechanics and also understand the function of a car, but it's actually quite different than driving from point A to point B. Before we actually bring them into the clinic and ward and teach them about clinical reasoning, we should encourage them to read about the theory behind it and how it's actually supposed to be done. In order to teach them, I would recommend that we use Peyton's model, whereby the steps of the demonstration, deconstruction, comprehension, and performance is done throughout 3 consultations. So basically, first we demonstrate, and then we deconstruct our demonstration for them. And the second consultation, as we do it, we check for the comprehension of our clinical reasoning skill, and finally we ask them to perform and recheck on them. In the first consultation is where we perform demonstration as well as deconstruction. This is in demonstration is where a clinician demonstrates a clinical consultation at their normal speed, where they usually will do in their regular practice, taking care to clearly consider a range of hypotheses and also differential diagnosis when during the consultation process. And either during or after the demonstration, the case should be deconstructed to the students. In terms of the presenting complaint, we shall consider the hypothesis and the differential diagnosis looking at the patient's presenting complaint, the key features of each of the hypotheses, and what are the differential distinguishing features between each of these hypotheses for the patient. When we continue our history taking, we should deconstruct to our students and explain each of these questions and why were they asked in the first place. We must also explain to them how this new data can actually help and also hinder this hypothesis. We should explain to them whether there's a need to reprioritize this hypothesis with this new information. We should explain to them how we refine our diagnosis, and from this diagnosis, how we perform physical examination in order to either support or refute our diagnosis, and finally, how we decide on certain investigations in order to confirm our diagnosis. After demonstration and deconstruction, when we move on to the next patient during second consultation is whereby we assess their comprehension. Now again, this is being taught by the teaching clinician, performed by the teaching clinician, sorry, but this time the student should actively track the consultation and they should outline the clinical reasoning when we demonstrate our history taking and also our physical examination. The clinician in this case should pause at each step in order to examine whether the students actually comprehend and understand what we're doing. We can ask questions like, can you list me your hypothesis? Can you tell me about the key features and distinguishing features of each of your in the patient in order to differentiate this hypothesis? You can ask the students, why did I ask this kind of question, and how does my question, the question that I ask, will affect the hypothesis and also the differential diagnosis. You can ask them, okay, what are the positive and also the relevant negative findings that I'm supposed to look for, and then examine it for them. And finally, ask them about definitive and helpful investigations that is warranted based on your physical findings. So after after demonstrating, deconstructing it for them, and then finally, and then after assessing their comprehension, this is where we ask them to perform. Now, in the third consultation is whereby the student will then follow the model which was outlined in the first and second consultation, and they will perform the history and physical examination, directing the investigation, explaining to the clinical teacher their reasoning as they proceed. If the student's reasoning is unclear, then the clinical teacher can actually interject with questions with things like, why did you ask that, and how does the information help you, and so forth, just to keep them on track. Now, be mindful that your responses are very important in order to encourage and facilitate effective clinical reasoning. Those are the list of questions those are the list of comments and also responses that can encourage them. Include things like, show me how you can come to that decision. That is a good thought. Can we expand on it? Where would we find answers to that? Let's try that one again, and so forth. So besides by using Peyton's model, we could also use a few more techniques when we want to teach our master students clinical reasoning. Okay, there are three other techniques, which is reflection, metacognition, and also deliberate practice. These are all big topics on their own, but I'll just be briefly talking about it. So what is reflection? Reflection is basically scrutinizing the initial diagnostic impression of a problem. This will require our students and ourselves as well to escape from the point of view of what our first hypothesis was, and then we look at the case from a different perspective. Sometimes it may be easier when we involve another person, when the master student involve our trainers. We can use metacognition. Okay, to simply put it, metacognition is thinking about one's thinking. It refers to the process that is used to plan, monitor, and to assess one's understanding of performance. It includes a critical awareness of the learner's thinking, and as well as to learn about how they think and learn. This can be implemented using case-based learning. We can learn this through simulated and standardized patient interaction and experiential learning. Another method would be deliberate practice. So this is where we have conscious and effortful working of components of expertise to improve them. And these are usually for a certain part of weakness that they have. For example, let's just say we're going through the process of through the skill of clinical reasoning, and we find that the student is poor in coming up with a differential diagnosis and unable to justify the differential diagnosis based on the history and examination. We should then give a clearly defined learning outcome for them, and give them a goal to achieve, and then they just keep on working on that. So this is deliberate practice on that particular set of skill. Okay, now how do we assess clinical reasoning? Now it's already not easy to actually teach it, so how do we assess it? I'm going to divide it into non-work-based assessment and also work-based assessment and also simulation. Now we're very familiar with non-work-based assessment. Non-work-based assessment are things like your MCQs, your EMQs, the essays, and modified essay questions, which we used to do, still doing, and certain things which we do not practice are things like key feature examination as well as script concordance tests. All these are non-work-based assessment. Work-based assessment will be what you see, how you assess the students in your clinical evaluation during your ward rounds, your direct observation. Global assessment, sometimes 360. Written notes, what they write and what they type, and how they plan their patients' management, as well as case reports. So these are all work-based assessments based on real patients. Simulation, we're talking about OSCEs, like what we do for our part 1. That one we can assess clinical reasoning as well. And something which we have not really practiced yet are things like virtual reality and also augmented reality. So we can use all these tools in order for us to assess clinical reasoning. Just some practical guidance for clinical reasoning assessment. There was a paper back in 2016 where they actually recommended how to assess clinical reasoning, and they summarized that when we assess for clinical reasoning, we should use multiple assessment methods. The assessment should provide adequate reliability. They should have broad sampling and provide sufficient testing time. To ensure competence in the assessment, we should have a large number of assessments, and it should be administered longitudinally. It should cover a variety of clinical problems to accommodate the context and also the content of what we're testing. The coverage of different components of clinical reasoning has to be valid, has to be feasible, is defensible, and should fit the purpose of the assessment. Some of the pros and cons of this non-work-based assessment or work-based assessment is what is shown here. The good thing about non-work-based assessment is that you can blueprint them. You can prepare a blueprint prior to giving it to them. So you can ensure that all students get the same thing. So it's very broad sampling. You can control the content and the feedback that you get, and it's quite consistent. You can also assess the accuracy of your questions and how well they are being answered. The problem is that you do not get good response process, so you do not know immediately how the response is from the clinical reasoning. You cannot really observe it, unlike your work-based assessment. And it actually measures a limited number of components when we talk about clinical reasoning. So then actually that is the advantage of a work-based assessment, is that it's authentic and it gives good response process validity because it's actually held in actual clinical practice, and you can actually observe the whole task of the student taking clinical reasoning. Now the problem with using work-based assessment is that the content coverage is not systematic. Very often the content is jumps back and forth, and the students wouldn't be able to assess the students' knowledge in all key areas, and actually it's very time and resource intensive. In summary, clinical reasoning is to integrate knowledge and evidence in order to come to a diagnosis. It is challenging because it uses both intuition and experience of a clinician and also analysis, and these things is not easy for somebody to learn, not very easy for a surgeon to learn. It takes a lot of practice. It's good having clinical reasoning, and teaching clinical reasoning is good because it ensures better patient outcome and makes you a better doctor at the end. The process of clinical reasoning goes through history, diagnosis, examination, investigation, and coming out with the patient's management. We can teach clinical reasoning with the pattern model, okay, whereby we first demonstrate, then we deconstruct our demonstration in one patient. Subsequently, in the next patient, as we go along, we ask them, they should interject, and we ask them to see if they comprehend what we have just demonstrated and deconstruct it for them. And finally, during a third consultation, ask them to perform and explain to you. Techniques such as reflection, metacognition, and deliberate practice is important. Techniques in developing clinical reasoning, and the key in assessing clinical reasoning is using multiple methods in order to have a good validated process with good response cues. So with that, I'd like to leave you with this saying that there can be no single way to study or best way to teach. Those were just some of the recommendations for you to try out and to follow. And these are my references. Okay, thank you.